Another medicine. There we go.
That was fantastic, Megan. Thank you so much. Really excellent. Um, let's see. I know I went to, wow. So, okay, so Dr. Temkin, thank you so much for coming from the all the way from NIH on the East Coast. So you know, we try to really add to when I'm coming up with what we're going to be talking about during our conferences every year. I really try to pick sort of what are the cutting edge issues and how we progress the field of gynecologic oncology and think about our practice. And what the talks, first two talks on the endometrial cancer staging, changing paradigm, and also on aggressive endometrial cancers and slow growing ovarian cancers, what all of that highlights is how much we need clinical research to teach us how to move forward. But we can't do good clinical research unless we have an inclusion in our clinical trials of all people and representation of diverse patient groups is absolutely essential to knowing how to provide good cancer care. So that's why the next talk is on inclusion of diverse patient populations in clinical trials. And that's really, really important for us to consider here in Alaska, given the composition of our state. So here you go, Dr. Temkin. Thank you so much for coming.
I feel like it's like such an honor to be here. This is great. Yeah, it is really an honor to be here. And this is my first time in Alaska. And I'm just really glad to be here on behalf of the federal government. So I'm just going to make a couple off the cuff remarks about the federal government because people may have read some in the newspaper about there's not a budget yet. So that does affect how the NIH supports clinical trials because we don't have a budget yet. But last year, the NIH budget was $47 billion, which all went to clinical and basic science, about half and half research to improve the health of the American population. And so that is the largest biomedical research enterprise in the world. And I think it's something that I'm very proud of. And I am glad to bring that here today, that pride here today. So my first slide is really about, my first couple of slides are really about some definitions and how we define a clinical trial. And so this is the NIH clinical trial definition. And as we've heard over and over again today, we can't have new treatments, new interventions, new drugs without clinical trials and the participation of patients in clinical trials. So there are 4 questions that the NIH says that or has designated as appropriate questions to determine whether you are participating in a clinical trial or not. Does the study involve human participation? Are the participants prospectively assigned to an intervention? Does the study's design allow the evaluation of the effect of this intervention? And is the effect being evaluated as a health-related or biomedical or behavioral outcome? And so these clinical trials can vary, and they can extend from new drugs, like we've talked a lot about today, to behavioral interventions, to population level interventions, to things like cluster randomized trials where people in one healthcare setting get a certain intervention and in others get another intervention. And so I know I'm not going to spend too much time on this slide because Dr. Hardesty talked about it already. You know, traditionally we think about phases 1, 2, and 3 trials looking at interventions to check safety, to evaluate effectiveness, and to compare an intervention against a standard of care. But I just wanted to also mention that there are phase 0 trials that look at a human component of something that's never been tested in humans before to see if that works the way it's expected. And also phase 4 trials, which are really regulatory evaluations of how things work in a general population after they've been tested in a broader population after they've already been approved for use in the regular market. And then my last definition that I wanted to just mention is about endpoints, because I think this is really important both for physicians who are looking at bringing clinical trials to their patients and also patients who are thinking about enrolling in a clinical trial. Is this a meaningful endpoint, and does this make sense? So the endpoint is what the trial is ultimately aiming to evaluate. So when we look at these, this is a busy chart, but I'm just going to highlight a couple things on here because these are the FDA endorsed clinical trial endpoints in cancer clinical trials. So overall survival is always going to be our gold standard of clinical trial evaluation. Does this intervention or drug make a patient live longer? But it's not the only one. And some of the downsides of looking at survival only is that patients can be living longer, but not with good quality of life. Reaching an overall survival endpoint can take many, many, many years. And then we're not getting information about these interventions to people who may need the intervention or the drug. And so some of these other endpoints may be more reasonable. A lot of our cancer clinical trials in ovarian cancer, for instance, use progression-free survival as an endpoint. And then the other endpoint I just want to mention briefly is a symptom endpoint or patient-reported endpoints, which have become more and more important, I think, as we try to center patients in our research more and more. And this means evaluating how well a patient feels, and that is taking information directly from the patient to evaluate whether the drug or the intervention is working. And so when we think about diversity in clinical trials, and why is this important and why does the federal government care about this, I'm just going to point you to this recent report from the National Academies of Medicine. The National Academies, for those people who don't know, is a large independent organization that does a lot of evaluations of federal policies. And this particular report, which was published last year, looked at improving representation in clinical trials of diverse populations. And so, I think the first of these is the most important, which is that a lack of representation of diverse populations within clinical research compromises the generalizability of the clinical research findings to the entirety of the United States populations. This is costly when we don't do this, and it can hinder innovation and also discovery. This also may lead to problems with access of the interventions once they're demonstrated to be effective, and also can undermine trust if we haven't used if we've excluded people from the trial, then they may not feel as though the intervention is appropriate for them. It may be seen as being appropriate for other people. And so because of this, if we are not intentional about who we put into trials, we can actually really exacerbate disparities that we know exist in the United States already. And so this report concluded that improving representation is an urgent need, that it requires investment, it requires transparency and accountability. And it's the responsibility of everyone. So not just me, the federal government, not just your doctor, not just the hospital where you get your care. And it's also part of creating a more equitable future and a paradigm shift. So just to take one step back and think about a little bit of history, it's not always been assumed or an assumption in medicine that including diverse populations in clinical trials was important. In fact, until 1993, women and minorities were actively excluded from clinical trials. Specifically, in 1977, the FDA banned women of reproductive age from being enrolled into clinical trials because it was felt to be unsafe for women who could potentially become pregnant to receive an experimental drug. And this was based upon a real reason. There was a drug called thalidomide that caused birth defects. However, it's literally only 30 years ago, 1993, when federal statutes required that the inclusion of women and minorities into clinical research that receives federal funding. And the FDA rescinded this ban on inclusion of women in clinical research. And our inclusion policies have changed somewhat over the last 30 years. And there's been various changes to how inclusion is considered. But it's actually only been since 2016 that the NIH set the expectation that female animals will be used in preclinical research. And there was a whole lot of complaining about that from the biomedical ecosystem because people felt like female animals were messy, they have hormones, and all of the rest of those stereotypes that we hear often. And only in 2019 did we extend our inclusion policies to extend to people of all ages, that it's important not just to include different people into clinical trials, but also that age of enrollment is another factor by which the NIH was setting an expectation. And so what's happened in the last 30 years, there's actually been really very good, there's been very good movement, I think, towards inclusion of women into clinical trials. For about the last decade, we have included women in NIH-funded clinical trials. At about half of participants have been women. There's also been pretty stable for the last 10 years. We've been pretty good at including racial and ethnic groups into clinical trials. So this is only the last few years of data, but you can see here that these numbers look pretty stable. And the numbers are really close to representative of what the racial categories that we see in our population as a whole. The majority of participants are white. Our population the white population in this country is the largest. And the same when we look at Hispanic patients, although Hispanic participation is a little lower than would be expected from the population. And so there are a few investigators who've looked at this over and over again periodically, like how are we doing? And actually, when you look at enrollment by sex, women versus men, inclusion has been pretty stable since 2014, with inclusion of women at nearly half of all participants in NIH-funded trials. And the same thing for and same for inclusion of underrepresented racial and ethnic groups. It's been pretty stable for since 2004. What has changed, I think, over time, and we, at least in my office, think this is good, is the inclusion of analysis by race, ethnicity, and sex that not only does the researcher include people, but also looks at, when the results are available, at whether different parts of the population did differently or had different outcomes. And so that has actually, analysis by sex has actually increased to, in 2021, it was 43% of studies included in analysis by sex, which is very much improved from 13% in 2004, but it's still less than half of clinical research studies. And analysis by race or ethnicity is much worse, with about a quarter of trials including an analysis by race or ethnicity. And I'm not going to go into too much detail about this, but there's a huge amount of missing data in race and ethnicity in clinical trials participants, which obviously makes an analysis difficult if we're not even collecting the data. So within this is the broad population of NIH-supported clinical trials, but what about in cancer clinical trials? And in cancer clinical trials, we know that men are more likely than women to get cancer overall. However, women comprised only 43% of the NIH-funded clinical trials that were conducted in the last 20 years. despite having a larger burden of disease. So overall, this suggests that women are underrepresented overall in cancer clinical trials. And I had looked at this a few years ago with a wonderful presidential management fellow who Grace Mishkin, who went through all of the GYN cancer trials that are NIH supported, and looked at how representative those were of the population. And so, and the comparison group was the SEER registry, which is a national registry of patients with cancer. And so I'm just going to highlight a couple of the really notable shortcomings that we saw. The average age of an ovarian cancer patient enrolling into a clinical trial was about 10 years younger than the average patient who gets ovarian cancer. So this has implications because we know that older women may have different comorbidities, may have less or more medical reserve when they enroll into a clinical trial. And may have different goals of care. So that was one issue. We also saw a higher than expected number of white women in ovarian cancer trials, and a lower than expected rate of Hispanic women in across all disease sites. So this has been looked at in a number of different ways with multiple different methodologies. I'm very partial to the way that we looked at this in this study because other investigators have found different results. But I just pulled another similar study to this that used similar metrics and a similar methodology. And these results were really pretty similar, that Black women with endometrial cancer or cervical cancer diagnoses were adequately represented, but Black women with ovarian cancer were underrepresented in clinical trials. White women were overrepresented or adequately represented. Asian and Hispanic women were underrepresented across all disease sites, and the numbers were too low to really meaningfully estimate anything for women who were of American and Indian descent, Native Hawaiian or Pacific Islanders, or women mixed race. And in terms of race and ethnicity reporting for gynecologic oncology, we're doing a terrible job. This is data that showed that less than 10% of gynecologic oncology trials that were registered in clinicaltrials.gov reported on race or ethnicity. And so this is a lot of evidence about why this is important and what we're doing right now, but how do we change this? We repeatedly for decades have only enrolled about 5% of our cancer patients across the country into clinical trials. And one of the reasons that clinical trials are not representative of the population is if we're only enrolling select patients, then we're subjecting the populations of patients on clinical trials to multiple barriers that include a lack of access. Even if they do have access, patients may have a lack of knowledge about clinical trials. Often patients are not offered clinical trials, and language barriers also affect accrual. So I pulled a couple of papers that looked at manuscripts that looked at how we can potentially, that give a few clues, I guess is the better way to say it, at how we can possibly start correcting this situation. When we look at this trial, this was a trial, a survey really asking patients about their willingness to enroll in a trial and whether they were invited by their physician or not. And so some of the reasons that patients enroll onto trials or it's meaningful to them is that they want to get better and they want to get better access to treatments that may not be available for financial reasons, insurance reasons, or because it's not known what the best treatment is. But I also highlight on this that about half of patients rate being altruistic or helping other patients as a very important reason that they enroll onto clinical trials. And sometimes, I don't know, this kind of always gives me a little bit of hope to see this because it's just part of like basic human participation in society is wanting to do things that are going to help other people. And I think sometimes we underestimate that in our patient populations. But I also wanted to note from this study, there were a few things that were associated either positively or negatively with being offered a trial. And so, so actually Black patients were offered enrollment into a trial more often than other racial or ethnic groups, which is a little different from what we think about normally. Having college education was also associated with being offered a trial. And notably, and I think especially meaningful for this audience, that living in a rural area was inversely associated with being offered. So rural residents were offered a trial about a third of the time of non-rural residents. And also when you look at who is offered, so the first step in getting into a trial is being offered the trial or knowing the trial exists. But I think when you look at what happens after a trial is offered, it's very important to think about this, because we often think about patients not wanting to enroll or not, or being uninterested or not having the transportation or not having the social support. However, over half of patients, if they are offered a trial, are willing to participate and or are interested in participating. And this is a population of cancer patients. Black, Hispanic, Asian patients were just as willing to participate as white patients. And I think I'm just going to actually quote the authors of this study here, who say that this strongly suggests that the observed racial and ethnic disparities in trial participation manifest earlier in the treatment planning decision process, and occur because of differences in the likelihood of meeting eligibility criteria, access to care where clinical research is conducted, and differences in access to physicians who conduct clinical trials. And so so this brings me to this point that access is also very important. And I think a couple words have been said about Oklahoma a few times today also, which I like to just mention, because this map on the left of this slide looks at where clinical trials are available in the country. And this is all clinical trials. And so you can see they're heavily weighted in big population states like California, Texas, Florida, New York. However, when you look at gynecologic cancer accrual, Oklahoma really stands out here as being one of the places where we have some of the largest accrual in the country. And I think everyone who knows about Oklahoma knows that that's because there have been an extremely dedicated group of physicians who have really made clinical trial access a priority for their patients. We also have ways to improve availability through the language that we use. And I'm not going to go into a huge amount of detail with this, but this is some NIH HIV work that's been done, looking at consent forms and taking out stigmatizing language. So language that may be around gender identity or sexual orientation. And just by doing that, they have demonstrated that they've been able to improve enrollment into certain clinical trials by making them more appealing to patients. I don't know these investigators, but they looked at the availability of language, consents in language of origin in gynecologic oncology clinical trials. And I assume that this was based upon someone taking away their translation services, because they had very good success at including Spanish language speaking patients into clinical trials until that service was taken away from them by the hospital, after which they had no Spanish language speaking patients enroll into clinical trials anymore, just highlighting the importance of making materials accessible to patients. And so there are site-specific workflows that can facilitate or impede enrollment into clinical trials. Some of these are very simplistic and things like having the trial available to patients, but there also may be ways of identifying patients who are eligible that go above and beyond an individual doctor being responsible for an individual patient and identifying that person. And so this is a slide from my very good friend, BJ Reimel, who has looked at using some digital technology and artificial intelligence to identify what patients might be eligible for what clinical trials based upon age, histology, previous therapy. And so this, is a potential use of technology for good instead of evil that I can support. We also hear a lot of talk about the need for clinical trial navigators. And whenever possible, I think we like to look at the Journal of the New York Times. But these are two examples of places where having a navigator available to patients to look for clinical trials helped increase minority population in clinical trials. There are a few structural interventions that I can mention. Back to the issue of Congress, in I think it was 2020, FY22, Congress mandated that the NCI, or the National Cancer Institute, set up a system for improving enrollment of minority populations into cancer clinical trials. And so some of the P30 or the very big infrastructure grants that are given to cancer centers were supplemented to create systems by which to improve enrollment of underrepresented populations. And you can see from the first year of this is reasonably new data that they were able to, that these 6 sites, I think it was 8 sites, were able to enroll large percentages of patients from underrepresented racial and ethnic groups and patients from economically underserved populations into cancer clinical trials. Decentralized clinical trials means that some of the trial-related activities occur at locations other than traditional clinical trial sites. I think these are lessons learned from the pandemic, that consenting maybe doesn't have to be done in person. Lab draws don't have to be done in one site. Radiology may not have to be done. For drug trials, it's sometimes difficult to do these things in a decentralized fashion, but for some behavioral science clinical trials, like the entire trial can be done remotely, basically. And so the FDA has draft guidance on decentralizing clinical trials. The comment period just closed, and so we hope that this means that more clinical trials will be brought to more patients with sort of a looser regulatory environment without losing the science. And the last thing that I'm going to talk about is this idea of return of value. And so I did talk a little bit about altruism at the beginning, but I'm also going to add to that by saying that also people like to get things back for when they put something into things. And so the concept of return of value in clinical trials has been sort of a novel idea of how to increase participation. Most patients are interested in getting something back from participating in a clinical trial. And in fact, it's most of what they want back is not that difficult to give them. For example, most of the patients asked in this trial for what they would want back, it's the results of the trial or their results that they're participating or contributing to the trial. And a large number of patients in this one particular survey did say that this was important to their decision to participate. And so a couple other things that were of note in this study that patients with more education were typically more interested in genetic results. African American and Hispanic respondents were more likely to to say that they would trust their researcher more if they do get results back. Alaska, American Indian and Alaska Native participants identified pharmacogenomics as being an important component of research that they'd like back, and younger patients were interested in money. For whatever people want to say about the youth today. So the NIH is actually piloting this idea of return of value in something called the All of Us study, which is a very big cohort study, really, where 1 million participants are having blood, electronic medical records. A large number of these people are carrying Fitbits, and the trial is designed to over enroll patients who have underrepresented racial and ethnic identities. And so as part of this, in 2022, all the participants in the All of Us study also have the option of getting genetic results or genetic testing. And so they are being tested for these genes that Dr. Pennington talked about today, about for their BRCA genes and a number of other genes. The positive or the abnormal results have been found so far in about 3% of the population who's enrolled. And each one of those patients has genetic counseling that's paid for as part of the trial. And so there's more to come, I think, about the acceptability of this idea, but I think it's really successfully piloting this idea of every person who enrolls in a clinical trial should be able to get something of meaning out of their participation. And I'm just going to end with one thing from my office, which is it's an outreach toolkit that covers how to retain, recruit, and engage women into clinical research. And if anyone's interested. And I think that is what I have. And if we want to go on to questions.